We're very excited to have Varun Aggarwal here, who's an interventional cardiologist over at Masonic Children's Hospital here at the University of Minnesota. I've known Varun for a number of years now, and I've heard him speak before, so you guys are in for a treat to hear about these congenital heart defects and the work he does over at Masonic. So Varun, thank you for coming and taking the time to do this.
Thank you, Paul. Thanks for inviting me. And good afternoon, everyone. So, how many of you are in the bioengineering or medical device? Okay. And anybody in medicine here? Probably. Okay, a couple of. So I'll keep it very basic, and please feel free to ask questions, and let's make it more interactive, and you guys can take home what you feel is the best for you. But what I have here is a large number of case series or case examples to show different devices and how we use in congenital space or pediatric space. And what is more interesting that some of you from industry may find interesting is we develop it on the go in pediatric world. Unfortunately, not many devices and catheters, they are made for children this size and small. So I'll show you some examples of how we innovate on the go, and maybe an opportunity for you guys to invest or do some research and make some new devices as well. These are my disclosures, and I will discuss, as I mentioned, some off-label products in my presentation, so they may not be FDA approved. So these are some of the common procedures I do on a daily living. It's the closure of patent foramen ovale or atrial septal defects, closure of patent ductus arteriosus, including premature newborns as small as 750 grams, patent ductus arteriosus stenting for ductal dependent pulmonary blood flow, transcatheter pulmonary valve placement, treatment for vascular stenosis and occlusions, and advanced interventional imaging, especially with the help of the Visible Heart Lab and Paul here, who has been a great support for a congenital program, and using of three-dimensional rotational angiogram and virtual reality and finite element modeling. So I'll show you some examples of how we use those in clinical practice. For those who are not in medicine, you know, this is a four-chambered heart, the right side of the heart and the left side of the heart. These are circulation in series, so to speak. The blue blood has to go through the lungs before it goes to the left side of the heart, and then it goes to the body. So that's why it's in series. Unfortunately, in congenital heart practice, that doesn't always happen. Some children, they're not born with all the four chambers, or they have big holes between the chambers, and essentially cause mixing of blue and red blood, and that gives rise to different scenarios and problems. But this is not how we start. When we start in fetal life, way before you're born, when you're in the mother's womb, you're not breathing, right? You can imagine there is no air in the uterus when the baby is in there, so the baby is not breathing. So not much blood goes to the lungs, and there is no way to oxygenate that blood that goes to the lungs. So it's only 10% of the blood 10% of the cardiac output is passing through the lungs. The rest of the blood is redirected through these fetal structures. So placenta is acting as the lung, and the placenta oxygenates the blood for the fetus, and it carries via the ductus venosus. Here it's a vein which carries an oxygenated blood, and this ductus venosus, which is the red structure, it takes the blood to the intrahepatic IVC, and then where it's a fetal structure, which is called as the ductus venosus, which is highlighted there, it transmits this oxygenated blood to the right side of the heart, and through the foramen ovale, it's preferentially directed to the left side of the heart, this oxygenated blood, and so that the oxygenated blood can preferentially go to the head and neck vessels. So we talked about two fetal structures, the ductus venosus and the patent foramen ovale. And I'll come back to these because I'll show you some case examples of how we intervene on these structures. And then, as I said, not much blood needs to go to the lungs. So God made this connection, which is called as the ductus arteriosus. So even on the remaining blue blood that goes to the right ventricle, it's preferentially streamed across the ductus arteriosus to the lower half of the body. So the head and neck and the coronary arteries, they get preferentially the oxygenated blood, which is redirected through the foramen ovale to the left side of the heart, and the more deoxygenated blood, so to speak, is going to the lower half of the body to supply the rest of the body. So if these structures, they remain patent after you're born, either the ductus venosus, the foramen ovale or the ductus arteriosus, then that can be a problem that may not be as useful after you're born, after the placental circulation is cut off, and that's some of the diseases that we'll talk about today. So the ductus venosus, this is a very nice case example of a patient that I had, and in this patient the ductus venosus closed, but it needed to be open, and this is an example of the 3D reconstruction from the CT scan of the patient, and you can see the portal sinus and the thread-like ductus venosus. So what this patient was 1 month old who was referred to me because he had an ASD, but ASD was not his problem. He was born with trisomy 21, some people also called it as Down syndrome. He had liver fibrosis, which can be associated with this trisomy 21, and severe portal hypertension. I've never seen this personally. He had esophageal varices, which bled on day of life too. So after he was born, so he had significant ascites, upper GI bleed, and it was refractory to all the medical management. And this was his baseline ultrasound. You can see the ductus venosus there and the color flow through the ductus venosus, and there was 9 millimeter mercury gradient. There should not be any gradient because the IVC pressure is essentially the same as portal venous pressure. The portal vein is 1 to 2 millimeter higher than the IVC. So this is a significant gradient across the ductus venosus, just a marker of the liver disease in this patient because of the portal hypertension. So this patient was not thriving at all. And this was the CT. I showed you the 3D reconstruction that we use for planning purpose. And then we went to the cath lab and went through the right venous access on the right neck, and then put a small catheter in the ductus venosus. And you can see these are all the portal veins, the dilated portal sinus because of the portal venous hypertension. And this catheter is a 4 French catheter, so it's basically like 1.3 millimeters in diameter, and that's the size of the ductus venosus. And this patient was, because of the size and because of the comorbidity and huge ascites, he was not a candidate of any other portosystemic shunt or a surgical shunt, so to speak. So that's when we decided that we can maybe balloon and stent this ductus venosus so that it acts as a relief for his portal hypertension and relief of his symptoms, at least transiently, because many of these trisomy 21 Down syndrome patients, the liver fibrosis may improve on its own as the child grows older. So we had a coronary stent, and again, so to speak, none of these stents, they're available for pediatric practice or for this age group. So we use off-label use of an adult coronary vascular stent, and it's a drug-eluting stent. It was placed in the ductus venosus, and there was good flow, as you can see on the angiogram here. And this was again the echocardiogram or the ultrasound that showed good stent and much improved flow. And on the last follow-up now I have is close to a year, and the child is doing well. His ascites has resolved. He had no more GI bleed. His portal hypertension is resolved, and he's thriving well. He has needed no intervention since then. Before that, every day he was getting a tap in his belly for his ascites, and then developing complications because of that, because of peritonitis and all those things. So I showed you, so first structure that we passed through in the fetal life was the ductus venosus. Then as the blood goes through, it's a patent foramen ovale that many of you may be more familiar with. And it's basically essentially a foraminal flap. And in pediatrics or in congenital space, we consider it benign. And it's gonna be present or remain open in 20 to 30% of 35% of healthy adults. If you screen all the people in this room or in this conference, you may find few who have a patent foramen ovale. And for most people, essentially, it's a benign finding. So when do we intervene? And then, of course, it's stroke prevention and redefining stroke prevention for PFOs that came up with all these studies. This is a busy slide. The goal is not to go over this, but just to see the advancement that happens in medical device industry. So the first 2 studies that we had, they did not show any improvement in PFO closure and prevention of secondary stroke, but these were either underpowered or because of the device, the device was not occlusive, and that's why you didn't have a good outcome. But then the device evolution, with the newer generation of devices, there's better closure and have more powered studies, and all of these found that PFO closure is beneficial for secondary prevention of cryptogenic stroke. So that's what's the indication nowadays, is cryptogenic ischemic stroke for secondary prevention. We are still struggling finding an indication for primary prevention. select cases of systemic embolization, platysmia, orthodeoxia, and professional divers. And just keep an idea on these shapes of the device. So this is for PFO closure because it's a small hole, and so that's why you have a small waist in the center. And then you have two big discs on each side. And what I'll show you is case examples of a ostium secundum atrial septal defect closure, where the defect is much bigger. So you guys, some of you guys who work with the industry, made a better device that would fill the defect and close the defect so the device would not move or embolize. So that's the third thing I'm talking about is the atrial septum defect. And essentially we can limit this talk to ostium secundum ASGs or hole in the center of the atrial septum. And the reason I say that is because all the current available devices, they need some tissue to capture in between so that the device does not move or embolize, so to speak, after placement. So that's why we always look for these patients, and we always look for adequacy of the rims all around the defect or all around the hole, and if it would be sufficient to anchor the device. Again, this is a case example from a patient of mine who was 2 years old and had significant dilation. As you can see, this is the right side of the heart, this is anatomical location, and this is the left side of the heart. You can see the defect, the large defect in the atrial septum, and significantly dilated right side of the heart. The two sides of the heart should be the same size, so you can see that this right side of the heart is almost twice as big as the left side of the heart. And this child was symptomatic as well. When he was running around, he was not able to catch up with children of his age, and because of this right-sided cardiac enlargement, it becomes an indication. And currently in the United States, there are essentially two devices. One was made here by Dr. Amplatz, Dr. Kurt Amplatz, and that's why our children's hospital was called as Amplatz Children's Hospital way back in the days. And this device was approved in 2001. And again, you can see that there was a waist in the center, and it essentially fills the defect. But these are two discs which are sandwiching the septum on the sides, and they come in attached by either a screw mechanism or a cable mechanism, some kind of mechanism, so it is deliverable, and the catheter and wires can come out. And it has been used for many, many years, thousands of patients across the world. One of the things that we found with this device was it's made of metal. It's made of nickel and titanium and nitinol. It's a self-expanding metal, but it's a metal inside the heart. So if it's touching the surface of the heart, then there is rare case reports, but it's real. About 1 to 3 in 1,000 patients you'll implant this device, they can have cardiac erosion, or the device may erode outside the heart, and it can be unpredictable. It may happen now, or it may happen 20 years later after the device placement. So, and these patients may present with sudden arrest or sudden not feeling well, present to the emergency room with a huge effusion, bloody effusion in the pericardial space. So that's why there are newer generation. This is a different company, but it's a similar device. It's called as the Gore Cardioform Atrial Septal Occluder, and as you can see, it's more fabric and as compared to metal, so definitely softer. It has again the waist in the center as compared to previous PFO device that we saw. That was a thin waist in the center, so it's a filling defect, or what we like to call it is a self-centering device. So it centers itself in the hole because it fills the hole. And this was approved in 2019, and it's a very nice device, and that's a beautiful demonstration of how the device sits in the septum. On the disc sits on both sides of the septum, and the device waist, so to speak, it fills the defect itself. And it's a very nice delivery system. It's preloaded. The device is loaded on the delivery system, and we as implanters will just have to flush it, and there is a nice delivery cable as you saw there. And the other beauty of this device, when you're making a device for us, is there are two steps. One is you can lock the device, and you can not release the device completely. It's still attached with a thread, and so if you don't like the device for some reason, or if it's not sitting properly, you can still retrieve it back into the catheter without causing any harm to the patient and not needing to snare the device out of the heart. So this is the example of the patient I showed you the ultrasound of. So you can see there is we always use fluoroscopy, but we use echocardiographic guidance as well. So this is a transesophageal echo probe, And we always rely on using the transesophageal echo for most of these smaller patients, for pediatric patients. And just the balloon sizing, as you can see, how big the balloon is, and there's essentially no waste on the balloon. Here is a slight waste that you can appreciate. That's the where the defect is, where the hole in the atrial septum is. And it's a relatively big device for a small child, but you can see this is the left atrial disc, this is the right atrial disc, and the waist in the center, which is capturing. And here the device is locked. You can see this locking loop that's coming out. It's like a metal, like a U-tape shaped wire, and it's locked in place, but it's still attached with that wire. So if for some reason you don't like it, you still can retrieve it back into the same delivery catheter that it goes in. So that's a very nice feature. And once we lock the device, we look with ultrasound and we make sure we like the device, and then once it's released, this is how it looks. And so having multiple steps of safety are always useful. So that's something that's different from this device versus the previous versions of the device. And this is how the device looks on both frontal and as well as lateral projection, and it's a beautiful device. One of the downsides, I was talking about erosions. In studies, what we found was about 25 to even 35% rate of fracture of the wire. So something is going to happen. If you put a metal device in the body and the heart is beating 1,600 times a minute, it's going to interact with the device. So the implantsa device, it eroded outside the heart. This device, I don't know if it was made like this or that's what the engineers claim, but or it's just happened that the wire frame fractures, but it's still encapsulated within the fabric. So the device does not unravel or open up, and it still functions. So if I look with an ultrasound, you can't tell if the device is fractured or not. Only if you do an X-ray, then you'll be able to see. But almost all of these, they are incidental findings just on X-ray, and the patient has no implications. So it's a beautiful device in that sense. This was the first study that led to the FDA approval of the device on 400 patients, which successful device placement in about 94%, and freedom from any adverse events at 1 month was 98%. But it's not perfect. It's not perfect by any means. We have been talking to the, I'm not sure if somebody is from Gore here in this audience, but they have been working for the last 3 years, I've heard, on making a new catheter. The catheter is very stiff. The delivery catheter is very stiff for some of these small hearts and large defects that we work with. So, like we have to innovate for our patients. So this is how the catheter sits. So this is the angle on the catheter that's designed, but the plane of the septum is like this. So it doesn't work. For the two discs to sit on the side of, if this is the septum, the disc has to be like this, right? If the disc sits like this, then it would slip through while you're deploying the disc. So that doesn't work. So that's what we found. One of the drawbacks is this is a relatively harder device to deploy because of the stiffness of the delivery catheter. So what we ended up using is like a long sheath which has an angle to it, and it redirects the catheter a little bit more favorably. So we published some of our experience, and especially in small patients with large defects, to make the device fit for us. But we have been told that they're coming up with a new software delivery system or a torqueable delivery system which would torque the catheter downwards and not make that angulation upwards. So some of these patients are not even possible for these. So like you see, one of the patient of mine, less than a year old, less than 5 kilogram, ex-premature baby who was struggling in the NICU for a long time and has a ASG, and some of these premature babies, the premature lungs, they don't tolerate ASG as well as any other child would. So our surgeon gives us access here on the right side of the chest. So this is on the right side up, and this is just the surgical markings before we started. And he gave us like an inch-long incision directly into the heart. Sometimes we have to do this if there is no vascular access. Unfortunately, if they have long indwelling lines and the thrombose, both the femoral veins or IJ, and there is no venous access to reach the heart, then we cannot go in there and do an intervention. So this was just an example of, and as you can see, the heart is so small. This is just the needle. The surgeon is just pushing the needle into the heart to find the right spot where we can go in with the needle. So you can see just the tip of the needle and the size of the heart, so how small the heart is. So this is and you can see it here through the heart. So this is just a needle going in there. It's a long video clip, but I'll pass through through it, and then once we make sure the needle is inside the atria or inside the right upper chamber or the right atrium, then we aspirate to make sure we are intravascular. There is blood aspiration, we confirmed, and that's when this is just a J wire or soft tip wire, and this is all under ultrasound guidance, all under echocardiographic guidance, and the wire goes in and we position the wire in one of the pulmonary veins under ultrasound guidance, and once the wire is in good position, I'm sorry, it does take 15-20 minutes for the procedure, so we have the whole video here, and once the wire is secured, the needle will come out. And what I wanted to show some of you guys, if you are interested, is there is no sheath for us that is made for these procedures. So, and there are certain drawbacks to the sheaths that we have that go through percutaneous access. They're not made for hybrid access. So you can see the dilator is too long. There are no markings on the sheath. We don't know how deep is. So we just use a ruler and make markings at 1 centimeter interval. So once the sheath is in the heart, we know how deep we are, and so we're not going too deep. Or so it's a low-hanging fruit if somebody wants to invest some time and energy in making a hybrid sheath for some of these procedures. And once the sheath is in there, then it's a simple device placement similar to a percutaneous device placement. It actually works wonderful because the axis is straight. It's perpendicular to the septum, so the device placement is much easier as compared to a percutaneous or through the femoral venous axis. It's just getting the right axis in the heart. And this is how the device placement looks afterwards. This is, of course, an Implanzer device. The Gore device is very hard to deploy through this axis because of the long delivery system that you saw in the previous video. So that's another drawback. It's a beautiful delivery system, but it has its own shortcomings. You can't use it in such a system where it's a small delivery landing zone. So coming to the next congenital lesion we talked about. So we talked about the ductus venosus, we talked about the PFOs or foramen ovale, and then the ductus arteriosus. It's fairly common. It's not that uncommon. It's essentially this connection between the aorta and the pulmonary arteries. So in fetal life, it was shunting, as I mentioned, it was shunting blue blood from the right ventricle across the PDA to the lower half of the body, so that only 10% of the cardiac output was going through the lungs because it was not meant to. The fetus is not breathing in utero. Now the child is out, but this was supposed to, just muscles were supposed to contract and become a fibrous cord, but that process does not happen. It happens more common in premature babies. But what it leads to, the aortic pressure is almost 3 times or more, or about 3 times the pulmonary artery pressure. So it causes the oxygenated blood from the aorta go back to the lungs. It's wasted blood. This blood does not need to be oxygenated again. So left to right shunting, left-sided cardiac enlargement, and some symptoms. Left-sided volume overload as compared to right-sided volume overload that we saw with an atrial septal defect. And premature infants, they are more prone to persistent ductus. And as I said, the premature lungs don't tolerate the extra left to right shunt, so it's more deleterious in those patients. And it comes in different shapes and forms. You know, all of us are born differently, and the PDAs also, they come in different shapes. And Dr. Krichenko, he made this classification from A to F. He made it from A to E, and now we came up with, for premature ductus or fetal type ductus, we named it as type F. But that tells us that no one device would be perfect, because the defect is different shape and sizes, so that's why we have different shapes and sizes of devices that are currently available. Some are on label, some are off label. Like the vascular plug is only a vascular occlusion device, but we use it commonly to close patent ductus arteriosus. Similarly, microvascular plug is used in premature babies who are less than 2 kilograms in their body weight, but it's not FDA approved for this indication. It's a vascular occlusion device as well. This is a new device, or the Implanzer duct occluder type 2 additional sizes, or now renamed as the Piccolo device, which is approved for these premature babies as small as 750 grams. So that's a big breakthrough. And of course, the Implanzer duct occluder type 1 and type 2, which are used in these patients. So this is an example this is a type A or a conical ductus that we saw in the classification. So you see this is a pigtail catheter, as the name suggests. It comes from the femoral artery, and then you inject a dye which opacifies the blood vessel, so you can see the blood vessel on X-ray, and these are just fluoroscopic images. And because of the high pressure in the aorta, the contrast injected in the aorta, it crosses the PDA, and it goes and opacifies the pulmonary arteries in this case, and that's how we see it. So this is a little bit right anterior oblique projection, and the other one is a lateral, straight lateral projection. And here you can see the nice conical shape of the ductus right there between the aorta and the PA. And then this is an Emplatzer duct occluder type 1 that was positioned in this patient. And as you can see, it's positioned beautifully across the ductus. And there is still some residual shunting. Most often than not, we do an ultrasound in these patients 4 hours later, 3 to 4 hours later before they go home the same day. And this shunt is gone, it's not seen anymore. And ADO1 is a nice device that has fabric inside it, so it's even more occlusive. So we're usually not worried when patients are hyperinized when they're in the cath lab, so immediate clotting may not happen, but some of that clotting may happen over the next couple of hours. So that was an Emplatzer duct occluder type 1 example. But what about the premature babies? These babies are very fragile, as you can imagine, 1,000 grams, 750 grams. Very prone to any manipulation that you would do inside the heart. And if anybody has to imagine how big their heart is, my heart would be size of my fist. So you can imagine a premature 1,000 baby and see his heart would be maybe like a pea. And maneuvering catheters through this heart, imagining from the right upper chamber, right ventricle, and across the ductus. And the other problem we have is vascular access. The femoral artery is so small. If you put anything in the femoral artery, it's a very high risk of femoral arterial complication and sometimes losing the limb, losing the leg because of arterial access. So as I said, this is a FDA approved device. It's called as the Piccolo device now. It was just Emplatzer duct occluder type 2, smaller sizes or additional sizes. That's how it started. And then off-label use of a Medtronic microvascular plug. And this is an example of one of my patients who was about 900 grams when he was referred, a month old. He was born at 460 grams, 22 weeks and 5 days of gestational age. He was struggling and he was on high frequency oscillator ventilation. And you can see how big the ductus is. That red flow, that's the ductus. The blue flow is the left pulmonary artery. So ductus is even bigger than the left pulmonary artery. So you can imagine how much of shunting is there or wasted circulation to speak. And that is evident from this 4-chamber view in anatomical position. So again, the left side of the heart, the right side of the heart, and the left side looks almost 3 times as big as the right side of the heart. So clearly this child was not doing well. As I said, no arterial access. We use fluoro, but it's mostly echo-guided procedure. And if you're making one of these devices, if you can make it more echo opaque, so to speak, so we can see easily on the echo, we can see all the discs on the echo. We still use some landmarks on fluoroscopy to deploy the device, but essentially it's deployed on echo, as you can see. And this is a Piccolo device. You can see the disc 1, disc 2, and disc 3 right here. And this is the aorta, and this is the left lung artery, and the device looks well seated in the PDA and no residual shunting, so it worked well for this child. Again, you see how the device protrudes a little bit. It's not a problem here, but sometimes that can be a problem with devices which have discs. They may go more than what you intend to be, and that may be a problem. And you have to oversize these devices so that they anchor, otherwise they'll just fly with the blood flow. So that's a soft bargain that you have to oversize the device, but not so much so that they would occlude the blood flow if you place the device. So we talked about PDA closure. I told you, like, some of these patients, they're not fortunate enough and they have hypoplasia of one or the other structures, either the right or the left side of the heart. And sometimes they're dependent on this ductus to be kept open to have adequate pulmonary blood flow. One of the traditional examples is tetralogy of Fallot, as shown here. So you see the hypoplastic pulmonary valve right here. So there is not enough blood going if there is stenosis or narrowing of the pulmonary valve. And this is an extreme example of same spectrum pulmonary atresia. The pulmonary valve is totally atretic, and there is no blood going to the lungs, so you can't live now, right? Like, there's no blood going to the lungs, there's no oxygenation happening. So if this duct is closed, you're essentially, you won't be able to survive. So you have to keep the ductus open, and fortunately now we have a medical prostaglandin infusion, but you have to be on a central line or some kind of IV line continuous in the hospital. You can't go home with it. So what surgeons used to do, and this is a beautiful operation, it saved many children. They used to do what was described as classic Blalock-Taussig Thomas shunt, or nowadays modified shunt, where they just sew a Gotex graft from the subclavian artery or the innominate artery to the right pulmonary artery most commonly. And this is the modified Blalock-Taussig Thomas shunt. Originally it was described like just cut the subclavian and put the subclavian directly onto the pulmonary artery. This has saved many children, but again, it's an extra operation, and if you can avoid an operation, if we can somehow keep the ductus that you were born with and keep it open without using medicine infusion, that would be something ideal. So nowadays, you can do a stent in the ductus arteriosus, and this was a patient of mine, 8 days old, 3.7 kilograms, born with pulmonary atresia, and had a ductus arteriosus. This was common carotid access in the right neck, because this was the most straight shot in this patient, and in an angiogram, as you can see, this is the main pulmonary artery, right pulmonary artery, and left pulmonary artery. So it's supplied well by the ductus. But it's not that simple in these congenital heart patients. So we always do pre-procedural planning using some kind of either echocardiogram, but many of these patients, they end up getting a CT scan for detailed anatomical evaluation. And then this was the ductus, and it's sitting on the bronchus. It's causing right bronchial compression. So now you have to interpret, if I'm going to stent this PDA, is it going to cause more problems? Because this is the last thing you want in a neonate, cause an airway issue. So thanks to Paul and his lab, Visible Heart Lab, we made these 3D models on this patient, and clearly it shows this is the pink or the light red as the airway, and you can see the clear compression of this ductus. And we made a 3D model as well in the Visible Heart Lab, and you see the huge ductus shown in red here and the airway in white, and of course the rest of the aorta here. But you can clearly see the bronchial compression that's present in this patient. What we did was we thought, what's the stent going to do? So we predicted how the stent, because the stent is not as big as the ductus, we allowed the ductus to constrict over a few hours before we do the stent procedure. And in this particular patient, stent was going to lift the ductus up, because it's a straight stent. Stent is not going to take that curved shape. It would straighten the ductus a little bit. So we predicted that it would lift the ductus up. It would be smaller in size, so it should cause less airway compression. And we went ahead and stented this ductus. And the child was doing very well. He ended up having, he actually had his Glenn operation in the last, since I made this presentation. So this is the pre-procedural CT scan that I showed you. This was the CT scan after the ductal stenting. We of course wanted to make sure we didn't cause any harm before he underwent his single ventricle palliation surgery. And then you saw this CT scan. This was from the post-procedure CT. You see the beautiful airway as we predicted, as well as the stent in the ductus. Now this is the real stent. This is the CT scan from the post-procedure. This is the 3D model from the post-procedure CT on this same patient. So it was one stone killed both the birds. It prevented the airway compromise, as well as kept the PDA open so that this child could live, so that he can get a next stage operation. Coming to the next, more fancy, nowadays we can do transcatheter valves, pulmonary valves, more to speak. On the adult side, they have been doing aortic valves, as many of you know, for a long time. But transcatheter pulmonary valve, many of these patients who was born similar, like pulmonary atresia or tetralogy of Fallot, they have some procedure as a child, and they are okay for 10-15 years of their life, and then they end up having free pulmonary insufficiency. The right lower chamber or the right ventricle of the heart dilates over time, and it's not good to have free pulmonary insufficiency and the dilated right ventricle. So this is an Edwards Sapien valve that can be placed over a wire, and this is a nice model. I'll show you some examples of these as well. This is just the journey of how these valves, it takes 10, 15 years, 20 years, and now we have newer valves in the market as well. And this is an example of a patient and some of the problems that we see in these patients. So this patient had a right ventricle to pulmonary artery conduit because, so just to go into, he had aortic valve stenosis, his aortic valve was not good. And in children, what we do is when the valve is not good, you use the pulmonary valve and the surgeon places it in the aortic position. So now you are left with no pulmonary valve. So they place a homograft or a conduit from the right ventricle to the pulmonary arteries, and that doesn't grow with you and can get stenosed and cause problems. So this patient already had all those procedures, and then at an outside institution had a conduit stent and a melody valve inside it. But if you see this middle, you see all these fractures here. You see this wireframe broken here, wireframe broken here. So this melody stent just fractured over time because of the cardiac cycles, as I was talking about the interaction of any device or any stent we place in the heart in a beating structure. And it had multiple fractures and it became stenotic again. The valve lost its integrity and the valve collapsed probably inside this stented conduit. So this patient came back and we placed more stents, more metal inside the same one, and a new melody valve inside the pre-existing melody valve. And it works well, but it only works for 10-15 years, and then these valves, they degenerate and they lose integrity. So that's another opportunity. If somebody wants to make a valve that would last our lifetime, that would be something very good. And many of these patients, they have native right ventricle outflow tract. Like as this patient, she was very small, 8-year-old, only 23 kilograms, and had tetralogy of Fallot and free pulmonary insufficiency, as I was talking about. So when surgeon repairs tetralogy of Fallot, what he does is he opens the valve. So the valve becomes leaky by definition. And you tolerate this leaky valve for 10-15 years, and then over time, because of the leakiness, the right ventricle starts to dilate, which is not good. And then we have to intervene. And I showed you an interaction of the blood vessel with the airway. This is another example of an interaction of a blood vessel with another blood vessel. You know, this pulmonary artery, main pulmonary artery and the right ventricle outflow tract is very close to the coronary arteries. And we always have to test the coronary arteries to make sure, because we end up oversizing the valve so that it anchors, right? But oversizing is you encroach on your neighbor. And if your neighbor has coronary artery, that's not gonna go well. So in this patient, the balloon was inconclusive. As you can see, it's very close. And if the stent oversizes a little bit, it's gonna cause coronary compression. So nowadays what we use is a 3D rotational angiogram and instant reconstruction and relationship of the balloon to the coronary artery. And only this 3D rotational angiogram gave me the confidence that the stent is not gonna cause any issues. So she had a sapien valve placed. And then you can see post valve placement, it was close, but it was as the balloon predicted. It was safe enough for her to get a valve and avoid another surgical valve placement, at least for now. So we took this example and we talked to our engineers. Victor Barukas, he works here in the bioengineering department, and Carly is one of his PhD students. And we discussed, there has to be something, there is nothing commercially available right now. There has to be something which can do this prediction for us before we take the patient to the cath lab, because it's an invasive procedure. Many times what happens, we take the patient, we do the coronary compression testing, and it's positive, and then it's a no-go. Then it's an extra procedure, then patient has to wake up from anesthesia or go to a surgical procedure for a surgical valve replacement. So what if we can use some of the finite element modeling? It's a fancy way of saying, like, predicting how the tissue would behave if you expand, and to simulate the balloon sizing. So this is what basically it looks on a computer model. So you segment these structures of interest, in this case the pulmonary artery, aortic root, coronary arteries, and then you expand the pulmonary artery to the intended diameter that you would expect for this stent to be placed. And you can have three scenarios. There is no coronary artery or aortic root compression. There is aortic root distortion, like in this case. You see you expanded the pulmonary artery and you saw the distortion on the aortic root before and after. Or you can have a coronary artery compression like in this patient. So we have only done a handful of patients so far, but it has predicted accurately in every of that patient. So that's something that may be useful in the future. And we are sharing this on an open share platform. So if somebody wants to take it on and make a subsequent model, and we're working on some of machine learning, because segmentation takes very long time, and machine learning to use some of this stuff. So there's definitely an opportunity here for many of these patients if somebody can work on these kind of models. And not all right ventricle outflow tracts are suitable for the balloon expandable valves that I have shown you, because the biggest balloon expandable valve is 29 millimeters. So the landing zone in some of these patients is bigger, so you cannot put a balloon expandable valve. So now, for about 2 years now, we have this Medtronic Harmony valve, and it's a beautiful system. It's not made of stainless steel or cobalt chromium or balloon expandable. It's made of nitinol, the same as the ASG or the PDA devices. So it's self-expanding platform. It's much bigger, as you can see, and you just have to express it out of the catheter, and it takes the predetermined shape, which is just based on the nitinol properties, and it anchors itself in the area of the right ventricle outflow tract. So this has been used in many of our patients, and it's a beautiful valve. But again, the tissue it's all from pigs or cows, so it's bovine or porcine, and that doesn't last for life. That lasts for 10-15 years, and then you have to have a valve replacement. Vascular stenosis or occlusions, not uncommon for many of our patients who have multiple procedures, multiple long ICU stay, and it can be in any of the veins, pulmonary veins, systemic veins, pulmonary arteries, conduits, coronary arteries, as well as the peripheral arteries. So this is an example of a patient with severe pulmonary vein disease. You can see stents in all 3 pulmonary veins, the left upper pulmonary vein, and then the left lower pulmonary vein was completely occluded. So recanalize those veins and put a stent, and all these stents are coronary stents because there is no stent which is made for pediatric indication for this size. So these are all coronary stents, 4 to 5 millimeter diameters. And then some of these patients, as I said, like they have been long, lengthy ICU stay, they have been in the ICU for a long time, occluded every possible vein you can think of. The right innominate vein, SVC, left innominate, left subclavian, and still needed, because I had short bowel syndrome, still needed venous access. And this was 10 hours and 8 stents later, and trying to recanalize some of these veins. And the whole goal was, he had some venous congestion, and but the whole goal was to get durable venous access for long-term central venous lines for TPN and other needs that this patient had. Again, thanks to Paul and what he does, and this is something innovative that we are doing here, and this is an example of a virtual reality on one of the patients who was planning on ductal stent. So I showed you an ultrasound or the echocardiogram as well as the CT scan, but when you're planning procedures on these tortuous structures like the ductus here, right here, it comes down, then goes up, and then comes down again. When you're taking these multiple turns, it's nice to see the structure beforehand and make a plan on what the vascular access would be. As I showed you, the carotid access or axillary access, or which access would be a better approach to prevent any damage in these soft structures. So we are doing more and more of these for planning cases and for planning interventions in these patients. And again, if any of you are interested, this is a brief blurb of the CHIP network which I lead nowadays. It's a good community. It's free to join, so feel free to go in there and see. There's a lot of learning tools and about congenital heart disease and both pediatric and adult. And thanks to Paul for inviting me and for your time. If you have any questions, I'll be happy to answer them. Thank you.
Very nice presentation. Maybe I'll start with one. You know, we know after you do a procedure like that, there'll be reverse remodeling. If you have a dilated, like, right side of the heart and you repair it, how long does that take in kids, and is it quicker than in adults?
Yeah, so what Paul is asking is, if you have an ASG and I showed you the right side of the heart is dilated, how long would it take for? In our experience, it's usually a few months. About 3 to 6 months is when we expect the right side or the left side of the heart to go back to normal size. Again, it's not guaranteed, and that's why we have certain criteria. So like, for example, a patient with tetralogy of Fallot who has free pulmonary insufficiency gets right-sided of the heart is dilated. And we know the normal right ventricular end diastolic volume is about 80 cc's index for the body surface area, so 80 cc's per meter square. If the right ventricle is dilated almost twice that size, about 140 to 150, it can still recover and remodel to normal size. Once it's beyond 160 cc's per meter square, or almost twice the size of what normal should be, then that reversibility does not happen from natural history studies. And so even if you give a competent valve, so to speak, in that patient, the ventricle would not probably come back to normal size. So that's why we wait only that long on some of these patients. So we monitor their ventricular volumes with MRI or CT scans and prevent them from reaching that threshold that has been shown in natural studies to be prohibitive of a favorable remodeling. Even in older patients, if you have not reached that cutoff, it should be the same time period for you to reach. So 3 to 6 months for you to come back to normal size. But if you have crossed that threshold, then it's a boat with a sink. So it's hard to do.
Questions from the audience? Yep.
So when you guys are doing valve replacements that for valves that were replaced when these congenital defects arose, are you doing valve-in-valve replacement, or are you retrieving the old valve and replacing the entire site with like another Medtronic valve?
So transcatheter, it's impossible to take it out, right? Once you have placed one and it's endothelialized. So we end up doing valve-in-valve. So even stent-in-valve and then valve-in-valve in the example that I showed you. So he had a PAMA stent inside it, then a Melody valve. We place another PAMA stent inside and then a Melody valve, because the Melody valve, the stent is not very strong and it fractures as in this patient. So to provide more durability for a landing zone, we have to do stents before that. Sapien is more strong, and if you have a sapien in there, you can do a valve-in-valve without doing a pre-stent. For transcatheter options, it's not an option to take it out. It's not going to come out because it's endothelialized after that many years. And even if it's going to come out, it's hard to take it out safely from the tricuspid valve tissue. So it's valve-in-valve transcatheter. If it's a surgical, then they end up replacing everything. Everything comes out and either a new conduit or a new valve goes in.
So just following up on that, on those patients, because they have these congenital defects, they're going to need more valve replacements than the normal person, because older patients may just need one valve replacement or two in their life. But how many times can you do a valve and a valve replacement before you are starting to get worried for this? It started off as a neonate and you fixed it, and now they're going to have what, 7 overall? Like
Yeah.
When do you start getting concerned, and when do you need to do a surgical approach to replace it instead of doing valve to valve?
Yeah, it depends on the patient processes mismatch. So the question which you're trying to ask is how many times you can do, because every stent would take the landing zone and you can only expand it that much. So every stent, if you place a new stent, it's about 0.5 millimeter, you lose on the landing zone. So if you ended up putting 7 valves in there, then your landing zone would be small, and it's patient prosthesis, so the valve would be too small for an adult size patient. Usually most people would do one valve-in-valve, or at most another, like a third time valve-in-valve, and then they'd go for surgical replacement. But these valves have been there only for 2 decades, as I showed you in the timeline. So this is an answer that would come in the future. And if there's a patient who comes to me and I can safely dilate the pre-existing valve and put a new okay size valve in there, then probably it's not as bad or similar outcomes long-term to a surgical valve. But you have more animal tissue. Does it predispose to more endocarditis or other risk factors? We don't really know. But we always calculate the landing zone. We put a balloon in there and we size the balloon and see what the diameter we are getting before we are putting a new valve in. But that's always a concern of it has to be appropriately sized for the size of the patient. Otherwise, it's not going to work.
Hi, super interesting talk. I was just curious, with when you put in these devices in like infants, they grow really fast. Is there a chance that like any of these like stents or anything migrate like as they grow over the months, or is that super common, or do you plan for that?
So I think it was there in one of the videos. So what happens, so I think you're talking about the ASD devices or PDA devices, because these are small kids and they're gonna grow quite a bit. The device endothelializes, fortunately. So, and that process starts in a month and finishes in animal studies, as far as we best know, in 3 to 6 months. So by 3 to 6 months, if the device is well opposed to the tissue cells should have grown over the device and it endothelializes. That's what the process is. Once that happens, the chances, the remaining normal tissue would grow. The device, of course, is not going to grow. So usually it does not cause any problems, and the device stays in there for life, and it does not cause, of course, there are some things that we talked about, like erosions and that kind of thing may happen if there's stiffer device, but usually most of these patients, they do okay.
I guess I have a question on the imaging. So I know, you use CT occasionally or often on these patients. Are you worried about using that radiation? And then the other follow-up would be echoes getting way, way better month by month. And then are these kids just too small to use ice, or can you use an ice down the esophagus or do some tricks like that?
Yeah, those are good questions. So we always worry about radiation dose, and what I do in the cath lab is all radiation, right? As low as reasonably achieved, or ALARA is the principle. CT scan, fortunately, nowadays our radiologists have gone much better, and the dose of radiation that they use for the CT scans, for these kind of scans, is much lower than what it used to be. It's still not perfect. I was told it's like 10 X-rays, so it's not a whole lot, but it's still there. And especially like some of these patients are gonna get multiple scans, multiple interventional procedures, so that's always a concern. MRI is getting better and better, but if you have a device, the device causes an artifact in MRI. Echo is good. We have now 3-dimensional echocardiograms as well. But we use all these studies. So I showed you some examples of echoes, some examples of CT scans, but we use all of them, and it has to be tailored to the patient. So no one study is perfect. And ICE, the main disadvantage is it is a 8 or a 10 French catheter. And the vessels may not be as big for an 8 or 10 French catheter. And even if it's that big, it's an extra access in these kits. So you're using one for putting the device, and then you have to get another access to put the ICE catheter in. That's an issue. I know some people have tried it in the esophagus, but it's a stiff catheter to put it in the esophagus, and I think it can cause some erosions or even lacerations in the esophagus. So that's why most of us worry about putting it. But I know people have done that, especially in older patients if you don't have a vascular access. But again, it's an uncharted territory. I have personally not used ICE in the esophagus. I worry about ICE catheter damaging the esophageal lining and implications of that.
Can you use a protective sheath, do you think, to help you? That's something softer sheath to go down the esophagus, and then...
That's a good idea.
Yeah.
I haven't thought about that. You can put a wire in the esophagus and put a sheath, and then put a catheter through the sheath. That's a doable, seems like a doable thing.
We're supposed to be innovating here,
Yeah.
so. Any other, good.
So I know that there are some congenital defects where you need like 2 things in order to live. So like if you needed the ductus arteriosus to remain open in order for the delivery, for the child to survive at least until they could get a different intervention, how early can you stent the PDA? Like how early can you stent the ductus arteriosus to keep it open?
There's nothing that prohibits us from doing it on day 1 of life, but nobody does it on day 1 of life, because nowadays we have prostaglandin, and we have to understand the anatomy better and sometimes get CT scans or more advanced imaging. These are tricky procedures. These are tricky procedures in the sense, imagine this child is relying on this ductus as the source of pulmonary blood flow. And from natural history, ductus is a tissue, the wall of the ductus or the media of the ductus, it's supposed to constrict. That's the natural course of that muscle. So when we put catheters and wires, sometimes spasm happens. So it's a relatively high risk procedure. So that's why planning goes a long way. So you have to make sure you have all the equipment, you know which access is straight to the ductus. So that's why nowadays we go through the carotid artery in some of these small patients instead of the femoral access, because you want to go straight like with a wire, because the wire tends to follow a straight course. So you want to get the vessel which is directly opposite to the mouth of the ductus to avoid those complications. So usually, realistically speaking, planning wise, it takes a couple of days, and talking to the family, because there's no urgency here. We have a medical drug infusion which keeps these patients stable. So realistically, it happens around a week of life or something like that for most of the patients. But there's nothing that prohibits you from doing it in straight from after the delivery. It's just planning and safety issues.
So, like patients with transposition, you can, would that be an option to keep them? Because I think it's transposition where if you have the PDA, you can survive. Is that correct?
So transposition. So for those who are not in medicine, transposition means your right ventricle is connected to the aorta and the left ventricle is connected to the pulmonary artery. So what happens is the blue blood circulates and the red blood circulates, right? And that's incompatible with life. So IVC, SVC, right atrium, right ventricle, aorta. Blood goes to the body, deoxygenated blood comes back to the right side of the heart, goes back to the body. So that's incompatible. So you have to have a shunt, right? So most of these patients, they have some kind of atrial level communication, and that may be enough. You don't essentially need a ductus. So if you go to developing countries, there may be patients who are late diagnosis of transposition who don't have a ductus open, but you need to do something. If you are beyond a month or beyond 2 months, definitely this left ventricle has been pumping to pulmonary circulation, low pressure circulation, so it gets deconditioned. So sometimes these patients, very rarely people are described stenting their ductus at that time or recanalizing the closed ductus, opening it up and stenting the ductus, but that's only in case reports, just to retrain the left ventricle so that increase the pressure in the pulmonary artery. Conventionally, surgeons used to do it by doing a PA band, and you wait 2 weeks and a week or 2 weeks and then retrains the left ventricle, because it's not, it gets trained to circulate to the pulmonary arteries at low pressure. So I don't necessarily think you need a ductus to be alive for a transposition physiology. You need a shunt. It could be a ductus, it could be a VSG, a large VSG, or an atrial level shunt. Most commonly, it's an atrial level shunt.
Thank you.
So I got another question for us. So we have all these chants now to do great imaging, computational modeling. So, you're using these 3D prints as aids. So if you're in the OR, would you want augmented reality, a hologram, the 3D print? I mean, what would be your futuristic optimal environment to be doing these procedures?
Yeah, futuristic would be real time, right? All these, as you saw, they need planning. The segmentation takes a long time. If you're talking about a 3D model, like a 3D print in your hand, it's very useful, but it's an investment. You have to have a good printer, you have to have somebody who does the segmentation for you and makes a good model. I know people are working on holographic imaging, as your real-time holographic imaging. So the interventionalist, and I'm skipping the name, somebody in Middle East is working. He has a machine already made. You put on the goggles and you input the DICOM image, and you have a holographic image right in front of you as you're doing an intervention. So you can plan on that. There are people who are also working on virtual reality and planning these interventions. So making a virtual reality model either from an echocardiogram or from cross-sectional imaging like a CT or MRI, and using those to plan the intervention, to put stents in there even before you lay hands on the patient. So I think futuristically it would be a combination of everything, because no one modality would be perfect, and there would be some utility on having a real 3D print in your hand and having the surgeon play with it multiple times. And then there would be utility of less cost and with virtual reality and augmented reality and holographic imaging, and less time investment and cost investment for those rapid scans and rapid scanning. And we are also learning more and more as we start using this. Initially, we'll spend a lot of time in looking at the model and planning it and trying to put stents, expired stents in them to look. Now it makes more sense, and and it helps your understanding of the anatomy better. So if you do 10 of these scans for the similar kind of disease, you may not need for the 11th patient, because now you have a better understanding of the 3D relationships and understanding of the anatomy, and all patients may not need it at that time. It would be a very good tool for training, I think, because nowadays in medicine, it's a complex environment, it's a stressful environment. It can be stressful for doing these interventions in small patients. So for training residents and fellows and helping them understand the anatomy, it would be a wonderful tool in the future.
Any more questions? We have time, or? All right, if not, thank you, Varun. That was fantastic.
Thank you.